Welcome to Pediatric Podcast for PedsCases.com.
Hi, my name is Dr. Kai Homer, and I'm a resident in radiology at the University of Alberta. This video is the third in a series discussing musculoskeletal radiology in children. We're going to focus on musculoskeletal injuries and go through some cases to help you understand how radiology fits into the whole clinical picture. In this video, we'll review our approach to pediatric shoulder radiographs. This module was reviewed by Dr. Adrienne Thompson, a pediatric radiologist at the University of Alberta. I'd like to thank the University of Alberta Department of Radiology for allowing access to images from real cases. All images have been de-identified and are used here for educational purposes only. You can find these slides at www.pedscases.com. After watching this video, the learner should be able to, number 1, describe an approach to interpreting pediatric shoulder radiographs. Number 2, recognize common injuries to look for when viewing pediatric shoulder radiographs. Number 3, recognize the anatomic structures visible on pediatric shoulder radiographs. So as I mentioned earlier, in this module we'll be looking at the approach to pediatric shoulder radiographs. I've broken this approach up into 4 sections. We'll start first by looking at the bone cortex, then next we'll look at the clavicles. After that, we'll look at the proximal humerus. Finally, we'll take a look at the glenohumeral joint. Let's start off with an AP radiograph of the left shoulder in a teenage boy for reference. Here, I've traced the major structures. The clavicle is in green, the humerus is in blue, and the scapula is in yellow. I've highlighted 3 parts of the scapula. Number 1, the coracoid process, number 2, the acromion, and number 3, the glenoid. So, step 1 of our approach to pediatric shoulder radiographs involves carefully looking at all the bone cortices for any breaks or steps indicating a fracture. So here I've drawn solid lines along the cortex, and this is where we would be looking for those steps or breaks. Step 2 of our approach is to focus on the clavicle, and the reason for this is because the clavicle is the most commonly broken bone in the pediatric shoulder. You want to look for any break in the cortex of the clavicle, and you're going to want to look at the sternoclavicular joint, which I've highlighted in blue, and the acromioclavicular joint, which I've highlighted in pink. The reason you do that is to ensure alignment is well maintained. Because proximal humerus fractures are common in kids, our third step is going to involve looking specifically at the humerus. We'll be looking for any cortical breaks, paying close attention to the epiphysis, which I've highlighted in pink, the metaphysis, which I've highlighted in green, and looking for any widening of the physis, which I've highlighted in yellow. Proximal humerus fractures tend to involve the growth plate, which makes them Salter-Harris fractures by definition. Last but not least, we'll take a look at the glenohumeral joint and make sure it is well aligned like it is in this example. The humerus should fit into the curve of the glenoid. On the AP view, the humerus and glenoid should overlap and make a lens shape. Using the pink color, I've highlighted where the 2 structures overlap. Now let's look at a case. Here we have a 16-year-old boy presenting to his family physician with a history of chronic shoulder pain. He has a past medical history of epilepsy diagnosed at age 9. So here we're looking at the left glenohumeral joint, and this radiograph is a special view of the shoulder known as the true AP view or Grashy view. Here I've highlighted some major structures: the clavicle in green, acromion in purple, the coracoid in yellow, glenoid in pink, and humerus in blue. To understand how the true AP view is taken, let's use this diagram. Imagine we're looking down at the patient from a bird's eye view while they're getting their x-ray. The patient is standing in front of a detector, and if you imagine that we're looking down at the patient, if they were to rotate 35 to 40 degrees to their left, to the side of the shoulder being imaged, in this case, the x-ray beam is going to line up perfectly with the shoulder joint. This is a 3D reconstruction of a CT scan showing the bony anatomy. Here I've highlighted some anatomy to help you get oriented. The clavicles are outlined in green, the acromion is in purple, coracoid is in yellow, glenoid is in pink, and the humerus is in blue. To help you connect the anatomy on this 3D reconstruction with the anatomy on radiographs, in the next slide, I've taken a radiograph from the same patient and superimposed it on this image you're seeing here. So as you probably recall from earlier in the video, on this view of the shoulder, it should show space between the humeral head and the glenoid. Instead, you can see how the humeral head abnormally overlaps the glenoid rim. This view is known as the scapular Y view. It is as if we're standing behind the patient looking forward, so the glenoid is on the other side of the scapula. Here I've highlighted the scapula in yellow and used the letters A and C to denote where the acromion and coracoid are located. I've also outlined where the glenoid fossa would be on the scapula. Normally, the humeral head should be centered over the glenoid as shown here, but in this case, the humerus has dislocated posteriorly. The scapular Y view shows us that the left humerus is posterior to the rough approximate center of the glenoid. That confirms the diagnosis of posterior shoulder dislocation. In this case, there are bilateral posterior shoulder dislocations. Here, we're looking at a CT from this case. I've taken 2 axial CT cuts taken at slightly different levels through the glenohumeral joint, which clearly show bilateral posterior shoulder dislocation. Let's take a look at a second case. A 12-year-old male comes in with left shoulder pain and he's unable to use his left arm. On exam, you find localized tenderness to palpation of the left proximal arm and decreased range of motion of the left shoulder. All pulses are present and sensation is preserved. A radiograph is ordered. So here we have an AP view of the left shoulder. When I zoom in here on some areas of this radiograph, you'll notice how, compared to the area I've highlighted in yellow, the area that I've highlighted in blue looks to be a darker gray. On radiographs, that darker gray appearance to the bone means it is made up of less dense bone than normal bone marrow. Normal bone marrow being what's inside the yellow box. So keeping that in mind, let's go back to the radiograph without any of the drawings on it. Do you see how there's a large, well-outlined area of darker gray bone in this humerus? This is a bone lesion, and in this case, it would be described as a lucent lesion because it's less dense than the surrounding bone. But what does the word lucent mean? If we pretend this rectangle is bone, and that there's a lesion here in the middle of it, you'll notice that this lesion appears whiter on the X-ray because there's more material, which makes it denser. So, denser structures look brighter or whiter, basically the same thing, on X-ray. The word to describe this type of lesion when it's denser than the surrounding bone is sclerotic. Again, if we pretend that this rectangle is bone, imagine that inside the area outlined by the blue oval, normal bone has been replaced with a bone cyst. Because the bone cyst is less dense than the surrounding bone, less dense structures appear blacker or darker gray on X-ray. So going back to the initial radiograph from this case, here we have a lucent lesion arising in the center of the medullary cavity, and this is actually a unicameral bone cyst, otherwise known as a solitary bone cyst. This is a benign fluid-filled bony lesion seen in kids. They typically occur in the metaphysis of the long bones, most commonly the humerus, as seen in this example. They tend to occur near the growth plate. Unicameral bone cysts commonly present as a pathologic fracture as seen in this case. This radiograph illustrates the fallen fragment sign, where a fallen fragment of bone is seen floating in the liquid inside the cyst. This fragment will remain dependent under the effect of gravity, no matter how the X-ray is taken. So let's take a look at the next radiograph. Here, we have a slightly different view of the same patient's arm, showing the fallen fragment of bone floating at the bottom of the cyst. And now I'd like to ask you to look up both of these articles and read them in their entirety. Just kidding, I'm totally kidding. This concludes part 3 of this video series. In the next video in this series, we will look at ossification centers of the elbow. Before we leave, we wanted to leave you with a few key take-home points. Number 1, a 4-part approach to pediatric shoulder radiographs is helpful to ensure all areas are looked at. The 4 parts are number 1, bony cortex, number 2, clavicle, number 3, proximal humerus, and number 4, glenohumeral joint. Number 2, the clavicle is the most commonly fractured bone in the pediatric shoulder. Number 3, proximal humerus fractures are a common type of Salter-Harris fracture to look for on pediatric shoulder radiographs. Thank you for watching part 3 of the Pediatric MSK Radiograph series on PEDS cases, and please stay tuned for the rest of the series.
Check out www.pedscases.com for more great podcasts, videos, interactive cases, questions, and more. Press subscribe on iTunes to get access to all of our podcasts. If you like what we do, please leave a review on the iTunes store, share with your friends and colleagues, or think about getting involved.